Welcome to the Fairbanks Ethics Lecture Series. I'm Robin Bandy. I'm with the Fairbanks Center for Medical Ethics. Just a few technical reminders. Our program is being broadcast and recorded today, and so I want to welcome those people that are joining us from IU Health North, West, Arnett, and Ball Memorial. I also want to remind everybody to turn off or silence your cell phones and your pagers. We understand that you might have to take a call during the lecture, but if you do, can you step outside to do that? We would appreciate that. I'm here to introduce Dr. Paul Helft today, but he's someone who many of you know quite well already. Dr. Helft was appointed the director of the Charles Warren Fairbanks Center for Medical Ethics in November of 2004. So as someone just reminded me recently, he has been with us for 10 years now, and he's doing an excellent job, we might say. We're very grateful. Dr. Helft is also a professor of medicine at the IU School of Medicine. He specializes in gastrointestinal oncology. He actually did his internship and residency and fellowships in hemato-oncology at University of Chicago, where he also did an ethics fellowship at the MacLean Center. His research focuses on the ethical issues in patient and doctor communication, and we're really happy to have him with us today to talk about his work on pain contracts. And so we want to welcome Dr. Helft.
Well, it's awfully nice to look out in the audience and see so many friendly faces. And several of my heroes are here, Patty Bledsoe and Meg Gaffney and others, so thanks for everybody for coming. This is a topic that I've thought about a number of times over a number of years for various reasons, but got to thinking about them a lot recently when the Indiana regulatory changes happened, and there were some hearings and a whole process that in the wake of the Indiana statute that mandated a set of changes around opiate prescribing. I also had the pleasure of directing our ethics consultation service at the Academic Health Center for about 10 years, and not uncommonly, the cases that we see involve patients who have various kinds of behavioral or addiction problems, and so pain contracts have been things that have come up in the past. So in any case, this is a series of thoughts, really, because I realized there was something that really bothered me about them. And so this talk has been an effort to try to work out for myself, really, what it is that bothers me so much about them. And I guess I came to the conclusion that I think we should abandon them because they don't allow us to uphold our sort of highest aspirations, in the words of Meg Gaffney. Because of that, but that's going to be a difficult thing to do, so I'm going to talk a little bit about all that in this talk. This is the mandatory disclosure slide. I don't have any relationships to disclose. And before I launch into the talk, I just wanted to make a few sort of caveats and disclaimers. So my argument is going to be that we should abandon the use of what I'm going to call written behavioral agreements in pain management because they do more harm than good. So for those of you who came to hear the conclusion, you can, take a nap now. I've titled the talk, a case rather than the case, because I think you could actually make several cases, including a case on the opposite side of what I'm going to say. So I don't want you to think that anything that I say, is a claim to having all of the wisdom that one might have about this topic. And I also want to say that for those of you who don't know me, my clinical context is very different from, say, primary care or specialty pain management, where the issues that many people face as clinicians working in those areas are quite different. So my patients all have most of them have advanced cancer. About 85% of my patient population has a cancer from which they will eventually die. And so I deal with patients who have lots of pain. But people sometimes fall into this trap of distinguishing more, legitimate forms of pain, like cancer pain, right? In fact, the literature really distinguishes between non-malignant sources of pain as if the malignant sources were sort of non-problematic. And I just want you to know that I'm aware of that distinction. I don't agree with that distinction because it raises a problem, but I just want you to know that I'm quite aware of that. There's also, as you all are very well familiar, an enormous amount of political pressure across the U.S. to make objective steps towards controlling the opiate abuse epidemic. And the recent regulations in Indiana are something that have certainly flown from that pressure. So opiate written behavioral agreements are sort of an objective step, one of the objective steps that one can take. They're measurable and auditable. And that's, I'm sure, one of the reasons why many states, including our own, has adopted at least a step in their regulatory pressure. And but even in the face of that momentum, which, you know, the horse may be already out of the barn, in fact, and you might argue back to me by the end of this that the horse is long out of the barn and there's no use in even talking about this. But I still think that we should approach a problem in a thoughtful and, most importantly, a data-driven way. And so what I hope to do is look at the data, what we have anyway. Pain, I also want to point out, as you well know, is, I would call it an ethical imperative. And that in and of itself is not a terribly complicated statement, but there are some complicated dimensions to that statement. One is that pain is a phenomenon which is entirely subjective. That is, it puts us in a position of reliance upon trust with respect to the patient's account. This is an area where, when a patient reports pain, we have no way of proving them wrong. We have no way of disagreeing with them, no objective way of doing that. So when a person claims to have it, there's a moral imperative, therefore, to believe him or her. Again, because we can't prove them otherwise by any objective measures. And we have the means, we in the profession have the means, we really have a monopoly on the ways of treating the worst kinds of pain. So minor kinds of pains, people can treat themselves in various ways. But when a person has severe pain of any kind, we really have a monopoly on the mechanisms of treatment. And so we have a great responsibility with that monopoly. And then this idea, I think, is really important. Pain is objectively bad. So, and I like to quote this author, Thomas Nagel, who's a philosopher, but he says that pain has what he calls objective disvalue. That is, it's not merely subjectively bad experience for an individual patient, but it's objectively bad when one considers the very nature of what pain is. And we therefore have a reason to eliminate pain regardless of whose pain it is, because it is an objective disvalue to all of us. And so another way of saying this, the badness of pain is real, irrespective of whose pain it is, whether it's mine or any other conscious entities. So here's the outline of the argument that I'm going to try to make, that written behavioral agreements should be abandoned, and opiate written behavioral agreements, because there's, as I'm going to try to argue, there's really no compelling evidence that they achieved their desired outcomes. Number two, that when you analyze them either as agreements or more particularly as contracts, which is what they were originally called, they are specious, coercive, and one-sided. And third and finally, that they fundamentally alter the doctor-patient relationship in what I'm going to argue are harmful ways. And so back to my original statement that the harms of these documents outweigh their goods. So written behavioral agreements were first actually identified in the context of the suicide literature back into the late 1960s and early 1970s, and when people began to draft what were called no suicide contracts. And they were commonly used in psychiatry, pain medicine, and addiction medicine, and in fact, I would argue now are probably in more widespread use than ever. And then this has been put into particular focus because of the epidemic of harms which you're all well aware of, even from the lay press, from prescription medications, mainly opiates, which have made them more popular and, again, have put political pressure on us to do something about that. So just quickly about the opioid epidemic. This is a histogram plot of unintentional drug overdose deaths up until 2007, so 37 years. And you can see, going way back, heroin was the main culprit, and then cocaine in the 1980s, and now it's mostly opioids, and that's it's a pretty dramatic rise, as you can see. Drug overdose deaths have followed, in fact, and you can see that even though heroin, cocaine, and benzodiazepine deaths have mostly stabilized over the past decade, deaths from opioids are still rising at a relatively alarming rate. And this has actually paralleled opioid sales in the United States. So the green line, just in case you can't read it, is opioid sales, kilograms per 10,000 people, and the deaths rising in congruence with that rise. And in fact, if you look at the literature that exists about where people who overdose get their opioids from, the majority come from diversion, from so-called legitimate sources. That is, they come from prescription drugs that are either found or sold or transferred or diverted. rather than coming off, the black market or being manufactured in somebody's basement or another. Now, originally these documents have been referred to as contracts, and then there was a movement in the 1990s actually to change that, what was felt to be really a misnomer, because they actually aren't contracts in the legal sense. And people really began to realize that the word contract in and of itself raised those sort of legalistic connotations and began to get away from it. So they were re-termed, and for the most part now are still termed agreements. And I have invented the term written behavioral agreements because I wasn't really satisfied that any of the other terms that have been used are descriptive enough and not judgmental. So these are all, what I'm talking about, therefore, is not oral agreements that happen between people, but written agreements. They are behavioral in nature, that is, and I'll show you the data for this. Most of them stipulate a set of behaviors or interdict a set of behaviors, and that finally they are agreements in the sense that these are not contractual documents in actual fact. So my first question, how effective are opioid written behavioral agreements in increasing adherence, which is really what they're meant to do, I think. So the goals of these documents include increasing adherence and preventing and treating drug misuse and addiction. And the best study out there is the Cochrane Collaboration Review, which was published in 2009. I've given you the reference here at the bottom. It's available online. This is the largest systematic review. Many of you, I'm sure, are familiar with the Cochrane collaboration, which does systematic analyses of a given medical intervention, usually, or a diagnostic intervention. They looked at 30 randomized controlled trials in addiction medicine, only 10 of them, so a third of them were in addiction medicine, and 2/3 were in other things, almost 5,000 patients. Most were conducted in the U.S., and what they found, unfortunately, is that most of the trials were of relatively poor quality and involved small numbers of people. And I won't belabor all of the conclusions that they come to, but the bottom line, and in their stated conclusions, were that there are not enough evidence available to recommend routine use of these contracts in health services to improve patients' adherence. So their conclusion is really that we can't say for sure on the basis of the evidence that these contracts do what they're meant to do, which is to increase adherence. And then just to review a few of the individual studies, this is a more recent individual study by Starles and colleagues published in 2010. They found 11 more recent studies meeting their inclusion criteria. They found that all of these studies were of fair to poor quality. 6 were accomplished in pain clinics, 5 were in primary care settings. These all involved opioid written behavioral agreements. 4 primary care studies examined multi-component strategies, so more kinds of help for the patients than an ordinary clinic might have access to. All of the studies were observational and rated as fair to poor quality. In 4 of them that had comparison groups, opioid misuse was modestly reduced by the figures that you can see, and in the other 7 studies, the proportion of patients with opioid misuse after the treatment agreements or urine drug testing both varied quite widely, and so there was no specific benefit found in those other 7 studies. So the authors conclude that there's relatively weak evidence to support the effectiveness of these documents. And say that again. Rated by whom? Rated. You mean who judged the outcomes? This was a review. This was a review of the literature. Yeah, so they reviewed 11 other papers that had populations large enough to study. All of this, I've read all of the other studies, and all of them are actually quite small studies, which tends to characterize all of this. I mean, I'll give you 2 of the studies here. So Birchman in 1995 published a small retrospective observational study of these documents and did find some positive effects on adherence. However, the authors in the study never defined what they meant by adherence. So it's difficult in that paper to determine whether they mean the same things that we might mean. And then in this other smaller case series, about 20 cases of patients with non-malignant pain, and actually who had a history of substance abuse, so this would be a population at even higher risk of opioid misuse, found no correlation between a signed opioid written behavioral agreement and subsequent abuse. Again, small study, very difficult to draw conclusions, and that tends to be true on all of the small studies, which is why the reviews are sort of helpful. So my conclusion from this about the effectiveness of these documents is that although the data, I would argue, are really inadequate to definitively answer the question, that we can say that there are no high-quality data to support such widespread use and endorsement by practicing physicians. And despite this, the Federation of State Medical Boards, the American Association of Pain Management, many state regulatory agents have all adopted the written behavioral agreement in an effort to prevent and treat drug misuse and addiction. So we've, the horses come out of the barn, and yet we don't really know if these documents are doing what they intend to do. And the rest of my talk will be about weighing those possible benefits, right? None of the studies that I've just cited actually exclude the possibility that there is some benefit, some objective benefit on adherence. And that said, what we have to do now is weigh that against the downsides to implementing them on such a wide basis. So one way of getting around this, and this was actually a little bit of a fad in the early 2000s, to say, look, these are not contracts. What they actually are is they're much more like informed consent documents. So one way of around my argument is just to say these are not really agreements or contracts that we have that are enforceable, but rather what they're trying to do is provide patients with information for their decision making. And I've put up here, which I will not belabor to this learned audience, the four kind of core elements of informed consent. I've stolen these from Ruth Faden and Tom Beecham, and these are the things that everybody agrees upon that you have to have as the minimum process of informed consent. And I'd like you to compare that against the largest study done of the content of actual opioid written behavioral agreements. So Fishman and colleagues asked 39 academic pain centers to send their documents along, and then they did a qualitative/quantitative analysis of the content of those documents and tabulated them. I've not given you the entire tabulation, but rather the most common elements that are found. And I would just like to read these with you carefully for a moment, and I want you to ask yourself, what are these statements actually about? So 90% plus of the documents had terms of treatment, had prohibited behaviors, had points of termination of the relationship. Almost all of them had stipulation of patients' responsibilities, education and rules surrounding treatment. Less than 40% of them had statements of goals, emergency issues, limitations on prescriptions, legal considerations, and staff behavior way down on the list, around 10 to 15%. So very little of the agreement signed between two parties actually pertains to those who are doing the prescribing. So again, I won't do the exercise, but in your heads you can do the exercise and compare that set of elements of these documents with the true nature of informed consent, and you will see that there's a disjunction between those two things. I also think it's useful to ask the question, how would these documents function if they were actually used as contracts? Now, in the early days, the first sets of objections to these were really to the words pain contract, right? And you can see why that would be an objectionable term. It strikes people incredibly legalistically. It sounds like something which, if broken, you could go to jail for or be fined for and so forth. And clearly they are not contracts, and I'm not trying to argue that they are in any legal sense contracts, but it's really helpful, and my lawyer friends and colleagues have helped me to try to take a legal lens and understand what the documents, how they might function if you viewed them through that legal lens. So I think it's clear that they serve at least one of several what I'm going to call pseudo-legal functions, again, not actual legal functions. One, they make the obligations of the patient in particular explicit. Two, they specify the consequences of non-adherence, which are things like, we might stop writing prescriptions, we might eventually not allow you back into the practice and so forth. They allow a pre-specified means of exiting the relationship for physicians, which is something that I'm going to come back to in a little while. And then maybe they provide some protection from legal risk. So you can imagine that, if the feds came down on you, the DEA investigated you, if you have a documented, agreement in your office, you can at least point to that document, and it might provide some legalistic protection from that risk. Now, legally binding contracts, and I'm sitting right next to one of my closest friends who's an attorney, and if I say anything wrong, you'll tell me that I'm saying something wrong. But legally binding, since you wrote this section, I guess you can't really do that, though, can you? So legally binding contracts, have to have a few kind of standard legal elements. One, they have to be by mutual agreement. They cannot be completely one-sided. You have to have ample time to consider the terms. There has to be an absence of duress or pressure. Think about that. They should not change the nature of the physician's duty. In other words, you can't contract to be less of a physician or to fulfill less of your obligations just because the patient gave you permission to do that, and the parties must be able to walk away. So in the case of written behavioral agreements, physicians can walk away from the agreements, but patients cannot, and you can begin to see how, again, just viewed through a legal lens, that many of these elements really don't make these very fair kinds of agreements. So are they really like what are called in legal terms adhesion contracts? So an adhesion contract is a standard form contract prepared by one party to be signed by the party in the weaker position. Usually a consumer has little or no choice about the terms. Adhesion contracts are illegal, right? They don't fulfill the minimum definition of a legally binding contract because of these facts. I will remind you from Fishman's study, which we just went through a minute ago, only 18% of those examined contracts contain language specifying the physician's responsibility. 80% of them did not. And so there's this real dramatic asymmetry between the responsibilities outlined in the contracts between prescribers and patients. And then patients, many of them are in circumstances where they have actually few choices of physicians. And I'm going to argue, fewer and fewer as time goes on, actually, as more and more people will opt out of long-term prescribing of opioids. So they're going to have restrictions by geography, health insurance, finances, and then availability of prescribers eventually as well. There are some other legalistic objections which one might make to these, again, if you were viewing them through the legal lens. They may be analogous to what are called unconscionable contracts. That seems sort of self-evident. But what that means in legalistic terms is that it's an absence of meaningful choice on the part of one of the parties, together with contract terms which are unreasonably favorable to the other party. You can see where I'm going with this. So some evidence suggests that most of them are written at least the 14th grade level or above. That may make them, in many senses, not understandable to the average reader. Signed under duress, right? So if a person is in pain, for example, you might argue about whether or not, we might argue about whether or not that represents duress. And then again, in all cases, I think patients sign these documents from a much weaker position because they have no opportunities for bargaining or revision. You can't, if you get admitted to the hospital here, you get a standard informed consent document for treatment. You actually are allowed to cross things out and say, I won't do this. And that's true in contract law as well, as far as I know. In these, I don't know of anybody whose practice allows you to say, well, we're going to cross out, elements 8, 9, and 10 because the patient doesn't agree. So I think an important question is, would these provide legal protection, again, or regulatory protection, because I think that's certainly one of the pressures to implement these and to sign them widely. And I actually couldn't find any studies, there may be some, but I could not find any that examined whether they provide legal protection from prosecution either by regulatory authorities or by lawsuits from patients. I did go back to the no suicide contract literature, and there are a couple of studies which I raise only as analogies to the question that I'm asking here because I couldn't find anything specifically in this area. In that domain, no suicide contracts appear to provide little protection, actually, to counselors in suicide malpractice suits. And in another review of the case law, contracting for safety was never enough to protect against legal liability and may actually lead to adverse consequences for the clinician. Again, 2 reviews that I would point you to if you're interested in this particular topic. So again, looking at these contracts through a legalistic lens, what could we surmise or learn from them? One, that they are analogous anyway to an unconscionable sort of contract, that they skew the terms so much in the clinician or the prescribing clinician's favor that if they were contracts, they would be considered unconscionable. 2, that they might be conceived of as illegitimate adhesion contracts because they force patients to sign them under duress and with a lopsided set of expectations and requirements. And again, I don't know whether they do, but they may or may not provide any legal protection by virtue of their role in documenting processes of informed consent. So I would leave that question open. I'm going to move finally to what I'm going to call the ethical risks of written behavioral agreements. So the main function of written behavioral agreements appears to be, and these are not my words, to control or modify a patient's behavior. And again, if you read through the elements that are largely in most of these documents, that's what they try to do. They specify a set of behaviors to which one must adhere and a set of behaviors which are in general prohibited in order to continue to receive one's opiates. And I mentioned this in Fishman's study. 9 of the top 10 most frequently identified statements in the contracts were statements requiring or prohibiting specific behaviors of patients. Now, the Center for Practical Bioethics in Kansas City, Missouri, actually got a group together, a group of ethicists and lawyers and philosophers and others together to discuss this issue in 2010. And they published a paper in which sort of a set of proceedings from this meeting in which they found a few things that were at least of general enough concern to the group to make it into the sort of top conclusions. One was the high reading level of most written behavioral agreements. In general, the IRBs mostly have a threshold of about 8th grade reading level. So 14th grade reading level, if that's the median reading level, is probably too high for the average patient to read, and therefore you might wonder whether they understand anything at all from such a contract. 2 is the adversarial or intimidating language found in many documents. And I would, go out, and many of them are available on the web, by the way. Go out and read them, and you'll see that some of them are couched in these sort of punitive terms. Third, that certain social groups, empirically, male gender, younger patients were more likely to be subjected to them, and also people with non-malignant pain than with malignant pain. In other words, that represents a kind of judgment that we make about the risk or legitimacy of the origins of a person's pain. And then finally, the imbalance of power, which are inherent in these. And I've tried to make an argument about why these represent such an imbalance. So what effect do these have on the doctor-patient relationship? I mean, it turns out that there isn't very much empirical literature to point to that I can, summarize for you to give you, a better color in this area. Merrill and colleagues actually studied a group of illicit drug-using patients and their doctors at one institution, one of the only studies I could find. Their main finding was that physicians and drug-using patients in a teaching hospital display mutual mistrust. Does that surprise anybody? Especially concerning, so no surprise there at all. How these findings translate to relationships with non-illicit drug-using patients, meaning the sort of, the average patient who walks into, say, a pain clinic or a primary care doctor's office, I think remains largely unknown. However, I would ask you to just imagine or work through with me for a moment that with the sort of legalistic language, the punitive language, the majority provisions which pertain to prohibition of patient behaviors, and the consequences of broken agreements, right, which are that you don't get your pain medicines anymore, might undermine trusting doctor-patient relationships, might undermine them in a very fundamental way. That's what I want you to think about for just a second, because I think they do. I think they undermine them in a very fundamental and important way. And the reason they do that is because they transmogrify core elements of the relationship which contribute to the very foundation of trusting relationships. They therefore profoundly alter the doctor-patient relationship. And I would argue that the doctor-patient relationship, in its essence, cannot be contractual. If it becomes contractual, then it is no longer a doctor-patient relationship. And so any attempt to implement such a contractual set of elements for such an important set of activities as managing one's pain is really to radically reshape and alter the doctor-patient relationship. So my main objection to them, despite everything I've said, is really that these contracts do something to the relationship that we have with our patients, which is so important that we can't ignore it. So what's the real reason for written behavioral agreements? So this is just a little armchair psychoanalysis, so Alan and Tracy and all of the other true psychiatric and psychological professionals in the room, you'll have to forgive me for just a second. But here's what I think is really going on. These documents are concrete documentable action items which can hold up to audit. You can point to one of these and say, look, the patient agreed to this. We said, if you do this, we're going to cut you off. We cut them off. And so in a sense, it provides this illusion of protection. There's something we can do in what admittedly is an incredibly challenging area of medicine. So don't get me wrong. Don't think that I'm naive about that. I think this is an unbelievably challenging area of medicine. And most importantly, here's what I think is going on. I think they provide a defensible exit strategy, and that's why we like them so much, from relationships with certain subgroups of chronic pain patients. And admittedly, those pain patients represent some of the most challenging and difficult patients in any medical setting. And I don't want you to think that I'm underestimating the behavioral issues that come along with that. So patients with chronic pain who may or may not also have addiction, those are by their very nature very difficult things. And then patients often are accompanied by their severe behavioral issues, which are both stem from and feed into their addiction-related problems. So these are incredibly complex and challenging things. But I think what's really going on is we write these because it gives us an easier out. Myra Christopher, who's going to be here giving this lecture next month, so I would invite you all to her. She led the Kansas City group that I just mentioned in 2010 from the Center for Practical Bioethics. This is a quote from an interview that she did in 2010 in the wake of that meeting. So she says, what's becoming common practice in many pain specialty clinics is using a pre-printed standardized form that says, if we're going to treat or prescribe controlled substance to you, these are the conditions under which we'll do so, and sign this document, and if you fail to do so, then we'll fire you from our practice. So I think she summarizes in that brief paragraph what is actually happening here. Now, practitioners feel incredibly frustrated about this, and every time I talk to, a family care doctor, a person who works in pain management, anybody who manages chronic pain, or talk to the house staff in the Department of Medicine, all of whom have primary care clinics, they say that this is the area of the greatest frustration that they face in their daily practice. Again, there are very little empirical data that I can point to, but I'm just going to mention this study, which is one of the few. It actually comes from the Rauderbusch VA Medical Center. They interviewed 20 practitioners, all of whom were involved in the prescribing of opioids for chronic pain. 3 broad themes emerged from their analysis: that they emphasized the importance of patient-provider relationships and asserted that productive relationships are essential for good pain care. They detailed the difficulties they encounter when caring for patients. They feel pressured to treat with opioids. They struggle with the believability of patients' reports of pain. You can imagine they have worries about secondary gain, about the opioids being diverted, and about abusive and difficult patients, which are often the sort of behavioral baggage that come along. And that providers in this study described the emotional toll that they sometimes felt with chronic pain care, feeling frustrated, ungratified, and guilty. So I hope none of this strikes you as surprising in any way. Again, this has been my own anecdotal experience in just about everybody I've ever talked to about this issue. So how do patients feel about it? Again, there's very little empirical work done on this. This was a study from UMass, focus group interviews with 17 groups of patients, with 3 to 7 in a group. 6 of them were conducted in Spanish. They had 72 patients. You can see their demographics there. They were all across all of the groups of all genders, ethnicities, and age groups. Most patients reported suboptimal interactions in these circumstances with their healthcare providers when seeking care for chronic pain. They acknowledged feeling disrespected and distrusted by their healthcare providers. They felt that they were being suspected of drug-seeking behaviors and having their self-reported symptoms dismissed as trivial or not warranting medical attention. So participants reported greater satisfaction when they felt, none of this will surprise you either, listened to when they trusted them and they were accessible to address their pain concerns between visits, used patient-centered approaches to establish goals and treatment plans. You could insert that sentence into good care of any kind, right? And that would apply really across all domains of medicine. Okay, so why should we abandon these? This is the summary of the argument, really. Our reliance on these represents, I think, an abdication of our deepest ethical commitments to patients, for the reasons that I've tried to outline. So it may be easier to use these as a grounds for patient dismissal. I'm certain that it's easier to use them than it is to go through the other non-contract-based ways of dismissing patients than it is to provide long-term, what appears to be ineffective, frustrating care with challenging patients in this kind of setting. It's especially difficult because by their very nature, such patients display behaviors which undermine our trust in them. They frequently do, and that becomes a very difficult dimension of the relationship. But again, I would argue that we cannot undermine their opportunities to trust us. We have to provide them with opportunities to trust us. So I would ask a question: are they consistent with our highest aspirations and honor our most profound commitments to patients' good? And I think that they don't. So just briefly in the last 5 minutes, and then I'd like to leave about 15 minutes for anybody who wants to ask questions or argue back or anything else. You might say, well, then what are your alternatives to doing this? Because number one, we're pretty far down the road, and number two, there aren't any easy alternatives. And I don't want you to think that I believe that there are any easy alternatives. I think there aren't. So one alternative that's been put out there is, so Savage actually argued for what he called a patient-centered opioid treatment agreement. The idea here was, okay, if there are problems with the agreement, let's change the agreement and make them more patient-centered. But I would argue that making the language of the agreements more patient-centered will not alter their function as these sort of pseudo-contracts, and so they won't actually change the damage that they do to the relationship. So I don't think you can write a document that somebody has to sign that will not alter the relationship in the ways that I've mentioned. So what can you do? You can have easier to say than to do, right? Caring, open, honest, and compassionate communication at all times with your patients. You can go through detailed, informed consent processes, which you can document carefully in the medical record. You can set limits, and I think it's absolutely perfectly within grounds to set limits, including even refusals to provide certain requested treatment. So I have no problem at all with, under certain, clinically appropriate circumstances, saying we cannot provide opiates anymore. What I have a problem with is that the documents provide us this out that makes it easy to sort of get rid of the most difficult patients. And an alternative to dismissing them would be to still provide care. I will care for you, but I will not prescribe opiates. So I'll do everything else in my power to help you, but I can't any longer prescribe opiates because of the following things. That would be an alternative. Not an easy alternative, but I think that represents an alternative. And I just mentioned in the last 3 slides other things that are going on around the country and the world because people have taken, some pretty novel approaches actually to the problem, which I just put out there because I think we should be looking as broadly at such a difficult problem. We should be looking at as broadly as possible at successful solutions. In North Carolina, Project Lazarus, as it was called, started in Wilkes County, which I believe in North Carolina was the county with the highest number of deaths from drug overdoses. They got together a coalition of medical professionals, hospital officials, law enforcement. It was really a model of how to do things from, an across-the-board kind of perspective. They used a multifaceted approach: community activation, surveillance, monitoring, prevention of overdoses through education, and then the widespread availability of rescue medications on ambulances and so forth. And actually, this rural county, at last report, had reduced its rate of death from opiate overdoses to almost 0. And so this is being rolled out all the way across North Carolina and all counties in North Carolina for that reason. So a nice approach, none of which involved a written contract. U.S. drug control policy, I would just point to this, I won't go through this slide in detail, as, in my own humble opinion, an abject failure. Mostly because we have criminalized everything there is to criminalize about drugs, rather than viewing them as what they really are, which is a health-related problem. And so, there's so much data out about this that I don't have nearly the time that it would require to go through this. I will point out a RAND Corporation study found that it was 10 times more cost-effective by looking at it as a medical problem which required treatment than interdiction in reducing the use of cocaine. And every additional dollar you invest brings you $7 or $8 in return on the back end. So that would be one way that we could, easily shift gears around the problem. And then I'll give you an international example from Portugal. So they had a very bad heroin epidemic in the mid-1990s with actually more than 1% of the entire population was felt to be severely drug addicted. So, that's an amazing number. So in 2012, by contrast, 20 times fewer, 20 times fewer patients were addicted in the United States, and the overdose deaths were on the rise. What they decided to do actually was to treat drug abuse as a health issue and not as a criminal justice one. And they actually decriminalized all personal possession of all drugs in 2000. No drugs were legalized, but people caught with small amounts were faced confiscation. And then the Ministry of Health began to put more resources into psychologists, social workers, and so forth to try to treat the problem as a health problem. What they have found in Portugal is that the heroin usage rates have completely leveled off. New HIV diagnoses have plummeted. Fewer teens are using illegal drugs. Drug-related crime is on the decline. Number of people seeking treatment has more than doubled, and drug abuse has been cut in half. So that's a pretty amazing result from, again, what would require, in the U.S. anyway, an enormous, change in our mindset. And then finally, if you want to look at a more legalistic, approach, which might actually be more applicable in the United States, you get a lot more mileage out of cracking down on pill mills, not cracking down on everybody or raising everybody to a certain set of ominous standards on how you manage your pain patients, but rather taking the few practices that actually do engage in illegal prescribing behaviors. So Florida actually did this. Florida was the state with the largest drug problem, still is, I think, by most measures. But in 2010, they passed a law that specifically focused on what are called pill mills, this practices which have this enormous, that's what they do mostly, is prescribe opiates to patients with chronic pain. And what they found is that by altering their access to, and by shutting down the ones that had the most specious practices, that their rates have also begun to decline as well. So I want to leave the last 15, 16 minutes for questions, comments, or anything else. Throw tomatoes. Hi. Okay. Yeah. Yeah. Well, I mean, so the regulations are now in place, right? And the statute was passed and demanded that the regulations be put into place. And I mean, I understand the political pressures to do this, right? We've got an epidemic. We need to do something. Once Kentucky, south of us, implemented a much sterner set of regulations, patients began to come across the border in southern Indiana. And so there was this sort of, I think, dramatic pressure to do it. I mean, I think so I went and, I don't want to say testified, but I went and presented a point of view to the advisory group, the group that was assembled by the General Assembly in Indiana to look at the issue and to write the regulations. And I said in the strongest terms that I knew how, here are some things that you are doing for which there are no good data to support. And I mean, I would argue that empirically anyway, these documents, if you just say, do they work or not, there are no data to say that they really work. And so, again, we jump on that bandwagon in the absence of data that they are, even in an evidence-based way, effective. So what could we do now that the regulations are already in place? I mean, I think the only tool we have at our disposal is to say no. I mean, to come together and to say, these are not regulations that we think, this is going to harm our patients in the following way. Right? Now, I mean, it actually doesn't affect very many of my patients because, like you, I mean, most of my patients who need, high levels of opiates actually meet the definition of terminal diagnoses, and so they don't actually fall under the requirement. But I have a fair number of patients who have treatment-related pain, let's say, that they will have for the rest of their life, and they will need this, and they do. So I think the only choice that we have. And I wish that we could have done this in the setting of, before it was all passed into firm regulation. But I think we could still stand up and say, we're not going to do things for which there is no evidence. And I mean, in my mind, worse than there's no evidence, I think it actually harms us.
Just because you parallel with the no suicide contract, I'm a manager for behavioral health services about this. We stopped using those a decade ago for the same reasons that you've outlined.
Great.
That they don't work. They potentially expose us to liability because we're implying that we put credence in this document that has been ineffective if somebody suicides, and it breaks the collaborative relationship between the treatment provider and the patient. So that's our one hope that we're hanging on to is that collaborative relationship. If we toss that out the window with this kind of adversarial contract, we've lost it.
Well, I thank you for your courage in doing that, and then for the testimonial. That's exactly what I'm saying. Alan? It's nice to see you back.
Thank you. Wonderful presentation, and I'm so happy to hear what your research has led you to believe. I would say in 40 years of doing emergency and addiction psychiatry, I've not used either one of these kinds of contracts, the no suicide contract or the open. However, I have to tell you, although psychiatrists are very used to ambiguity, it has been amazingly difficult for me to talk myself into continuing to work with these patients without something like that in place because all of my colleagues, or a lot of my colleagues, I can't say all, a lot of my colleagues in addiction medicine think I'm doing very bad things by trying to get my patients to the point where they decide that they are going to change their lives and get off of these kinds of substances. I would also point out that there are different populations that probably respond to different things. We see that all the time because of different genetics or different behavioral aspects. And so if one does an overall study with all comers of whether people respond to these things or not, I think you're going to get noise rather than signal. in the making. In other words, I think you're going to get a non-result rather than find something that works. And I would ask you, would there be a way to do this research to find out if there are people for whom these agreements work? You stop and think about obsessive compulsive folks who sign an agreement and then they wouldn't try suicide without calling, or they, because that's what they're going to do, right?
Yeah.
I mean, would there be a way to look at that? Because just like when we look at genetics and some people have different enzyme combinations, there may be different behavioral aspects for whom these things would really be good, and others for whom they are truly detrimental. Now, your argument is it's always bad for the relationship.
Well, I think, Alan, as usual, that's a really good set of objections to everything that I've said. And and here's why. I personally, when I've talked to people about this, which I've been doing for a year or so now, I hear practitioners in this area say, I had this patient, where we did an agreement, and it was the one thing that was crucial in helping them over some hump. So, that an agreement like this might not be beneficial in somebody in a particular phenotype. I'll buy that, absolutely. And I could even, in some sense, buy the idea that if we could identify who that was, and that's the problem. So my objection back to you is, I don't think we can identify who this is without, an awful lot of research into it. And so because we can't identify it, you have to do it then scattershot, right? You have to do it to everybody on a population level. And then I think that the harms of it outweigh the good that it might help for one. But I like your objections. I think they were very valid. If you wait long enough, somebody will always raise their hand.
So if you look at the regulation as phrased, clearly there are lots of exceptions, and you may be right that most of your patients don't fall under them. But the wording is not particularly precise throughout the regulations. There's going to be indeterminacy, and that usually tends towards regulatory creep, that risk managers are actually going to apply those contracts and mandate those agreements in more cases than perhaps a strict reading of the regulation would have you do. So it's highly likely you're going to see an increase in the use of these agreements, even perhaps an increase that is greater than that desired by the legislature in, as you have well documented, its complete lack of wisdom. So assuming that they don't change their minds, what kind of research can be done to actually start documenting the very problems that you have isolated out, you've described?
Yeah,
and while I have the microphone, the physician-patient relationship does have contractual implications.
And actually, I know something about the literature on this sort of fiduciary and contractual obligations, and there are clearly some inviolable obligations. So absolutely, I didn't mean to imply that was not the case. You make a couple of really good points. One is, indeed, I believe that there will be mission creep here. That what we will do actually is begin to apply, and what I think will happen, partly as a consequence of that creep, is in fact it's going to take some prescribers will opt out of the system entirely because it will become burdensome enough to enough of a proportion of their patient population that they will say, I can't do this. If you talk to the average primary care doctor right now, what's the first, if you say anything wrong with your practice, what will they say? They say, I don't have time to pee, right? Let alone, go through, and then how do you audit it, right? If you've got mandatory urine drug testing for a population of your patient, are you really going to be able to keep up with that and so forth? Don't get me started on urine drug testing. That's a whole other issue, actually. But so, yes, so I completely agree that I actually think the problem will exacerbate. Now, what kind of research we can do? What's missing from, there's a lot of things missing from the literature. I shouldn't just imply that one thing is missing. The literature on their effectiveness, I think, is wholly inadequate, really, to answer the question. And so we could be missing, we could be making a type alpha error, right? We could be missing a positive finding in here. What we don't have, though, are the stories of the people who've made this work without, in the absence of contracts. I mean, your 10-year history, thank you for sharing that story. I think it's a great story. And I would be willing to bet, since I don't know many people, that there are others that have, who swim in that same stream rather than the other one. So I think we could, raise our voices in a sense and get heard about this. I don't know that it will have an impact because I worry that most things are made on the basis of political considerations rather than, data-driven, outcome-based considerations, unfortunately. You are exhausted. Okay, thank you so much for coming, everybody.